So I would first like to introduce our first speaker of the day, that is Dr. Caroline Apovian. I hope I got that right.
Yes.
Yes. Dr. Caroline is the co-director, Center for Weight Management and Wellness, and member of the faculty at Harvard Medical School. And she is the co-director of the new Center for Weight Management and Wellness in the Division of Endocrinology, Diabetes, and Hypertension at Brigham and Women's Hospital, and a member of the faculty at Harvard Medical School. For over 30 years, she has held a position at the forefront of obesity and nutrition. One of the world's premier weight management experts, she has distinguished herself as a leading researcher, healthcare provider, teacher, and New York Times best-selling author. She has published over 10 books and over 200 peer-reviewed original research and review articles on obesity and nutrition. And she's going to talk to us about obesity management and how one suit does not fit all. Over to you, Dr. Caroline.
Thank you so much, Dr. Deshpande. I want to share my screen. Aha, okay, here we are. Okay, great. So I'm going to talk about how we treat obesity in general in the United States and around the world, and how we still don't understand that one suit doesn't fit all, and we need to take each individual's history and find the right treatment for them and why that might be. I cannot advance, so perhaps, let me see.
Are you able to do that, Dr. Caroline?
I don't seem to be able to advance. Oh, here we are.
Right.
Okay. So we have a familiar story that many of us who treat obesity know about. So, you know, two friends decide they're going to work together to get healthier. This is a very good idea because support from your peers has shown to be helpful in the fight to lose weight and keep it off. They develop an exercise regimen, change their diets. They send each other encouraging messages and tag team meal preparation. They decide to get more sleep and adjust to their new lifestyle. And after a few weeks, both have lost 5 pounds. And then another month goes by. One person has lost 10 pounds and the other remains stuck at 5 and frustrated. And this is a familiar story. People who are on the exact same diet, completing the same workouts, experience different results. Why is that? And this is also true if you calculate the diet, the calorie reduction based on the current BMI and body composition. Even if you give 2 different calorie regimes based on the person's body composition and the same workouts, again, based on the body composition, you can get different results. Why is that? It's because we realize, we realize this, but the body was always doing this, that there's something about nutrients coming into the body that is different in each person. In other words, we realize that there must be differences in people's metabolism, that some people take those calories and are more able and more efficient at storing them than others. And others have more futile requirements. Futile meaning they burn the calories and waste those calories more than others. And we need to figure this out, but we haven't yet. We don't understand fully the differences in why some people store more fat and others don't. And there are differences. The in the way people break down calories of different macronutrients. And that's why not one type of diet is good for everybody. All right. So until today, the world has approached obesity from the energy balance equation, calorie input and output, not the recognition of how complex obesity is within the body. And also, there's not one path to obesity. Just like there's not one path to weight loss, there's not one path to developing obesity. So there are many obesities. So beyond eating and exercise, there are environmental factors, behaviors, and genetics which play a role. And everybody has a different way that the environment has approached them. In other words, yes, in this environment, we are all gaining weight. Most of us have gained weight, but there are differences in the amount of weight we've gained and in the increase in our set points. We all have an increase in our set point in this environment, but some people, their set point has increased by 100 pounds, and others, their set point has increased by 10 pounds. Same environment. So everybody's unique. And so there's not just one obesity, but many different types called the heterogeneity of obesity. And this is so on our minds in obesity medicine that we've created a team. Dr. Gordon Larson in North Carolina has created a team of many researchers across many departments to try to study this. So, and how are they studying it? They are trying to understand why two people who consume the same diets and exercise equally can have very different susceptibility to gaining weight in this environment, okay? So the goal is to develop treatment approaches that go beyond this one size fits all approach. This here's your diet, here's your exercise plan. It's the same for all of you. If we can develop treatment plans for each individual that that we know can help each person based on this research, it would be great. So how are they doing this? They're looking at animals, first of all, but also looking at humans and giving the study subjects scales, exercise tracking devices, diet apps, and a glucose monitor, and allow people to follow different diets, provide meal frequency recommendations and exercise approaches. And then they're going to combine all this data and also from the animals to try to figure out if there are any common threads, i.e., can we develop genetic predispositions, genetic types, in other words, and give them, and then be able to give a personalized diet and exercise program for these types. This is going to take about 20 years. And so until this is available, precision medicine in obesity, it's called, we developed a guideline that was published by myself and my colleagues in JCEM in 2015 to help doctors give diet and exercise programs and medications to patients. And we specifically recommend different diets, exercise, and drugs and surgery based on certain conditions that you can develop based on your history and physical exam. Lifestyle changes is a central part of any weight loss program because we don't have the magic bullet. Not even bariatric surgery is going to help people lose weight and keep it off without changing the lifestyle. Now, in terms of drugs, all the drugs that are available, and this is a panoply of the drugs that are available in terms of their studies and the patients in the studies that have lost over 5%. Here you have it in different colors and compare it to placebo in each for each drug. And you see that in the colors, the drug increases the magnitude and likelihood of weight loss. So in the colors are the graphs of the patients, the percentages of patients who lost 5%. It's good, but it's not 100%. So some people, that means that, whatever, 25% of people on Fentope did not lose 5%. That's what that means. So even the drugs don't give definite weight loss for everybody. This is what this graph shows, that yes, it increases magnitude and likelihood, but not for everybody. You're going to hear more about drugs later on today, and drugs are indicated for those patients with a BMI over 30 or over 27 with one comorbidity. And here are some of the drugs that are out there. These are all the FDA approved drugs. And as you can see from this graph, we have graph percent weight loss. This is average. These are averages, the mean weight loss in the studies that were presented to the FDA in the United States. And what it shows you is average weight loss, which means just average. It means that some people lost less weight than this, and some people lost more weight than that. That's what that means. Now you can see that there is a distinct increase in weight loss, as you go up this x-axis. And of course, we have the blockbuster drug that just came out, semaglutide, which we're waiting for the pharmacies to get in. But notice that even with semaglutide, it's an average. So not everybody loses weight. And I'm going to show you that later on. Where do these drugs work? Well, most of them are appetite suppressants, meaning that they suppress appetite centrally in the brain. So they hit the set of neurons in the brain that regulate energy balance and affect appetite. But appetite is just one of the factors that governs your body weight set point. There's appetite, energy intake. There is energy expenditure and how you burn calories, all right? So there's absorption of calories in the gut. So appetite is just one factor here. And these drugs, as I said, work on the appetite regulation set of neurons in the hypothalamus and the arcuate nucleus. There are two sets of neurons, POMC-CART and agouti-related protein. If you activate POMC-CART, you get satiety. So some of these drugs activate that center. If you activate the other side, you get hunger, and some of these drugs block that, all right? And then some of these drugs also block the feedback inhibition. So they all work here except for the fat blocker, orlistat, which works in the gut to block fat calories from being absorbed. So this is the drug that has an alternative mechanism of action, gives you very modest weight loss compared to the appetite suppressants. All right, now the new drug, semaglutide, you're going to hear about this later. It is a GLP-1 analog, meaning that it works peripherally, but also centrally. We realize it works centrally to regulate appetite and food intake. So that's where that drug works. And here's the thing, more weight loss than the other drugs, which is right here. But when you look at the categorical, yeah, it's great. It's, 86% of patients lost at least 5%, and a third of patients losing greater than 20% weight loss. That's amazing. That's like a lap band. However, 14% did not lose 5%. So once again, not everybody lost weight. What's different about those people? We don't know. We need to figure this out. All right. Weight management, yes, it's great for helping people keep the weight off as long as you're on the drug. That's very key. If you stop the drug, your appetite comes back. All right. Here are the drugs again, and the type of weight loss. Notice that, some of them are very modest weight losses, not even 5%, and others are more than that. They all work in the brain. The dosing, there are several dosing regimens. So, in other words, some people can get weight loss with a low dose, and others you have to push the drug to the max dose. Again, individual dosing required for patients. Not everybody gets the same dose. And you'll hear more about that later. And whereas phentermine combined with topiramate and liraglutide until Wegovy came out, semaglutide, are associated with the greatest weight losses. This is average. It doesn't mean some people lose more weight on naltrexone bupropion because they have addictive qualities to their eating or binging. And we know that those people do better on the combination of naltrexone bupropion because naltrexone is an anti-addiction agent. So I'm giving you a flavor of not, when you use these drugs, you have to really take a look at your patient and try to figure out which drug might be the best for that patient. Pros and cons for these drugs. Again, you're going to have to get a history and figure out, for phentermine, the side effect is a problem. Side effects of phentermine are elevated pulse, blood pressure, anxiety, and insomnia. If you have a patient who has heart disease and elevated blood pressure, you may not want to give them phentermine. If you have a patient who is of childbearing years, topiramate is a teratogen. You may not want to give them topiramate. Okay. If you have a patient who suffers from, loose stools, you may not want to give them orlistat because it already gives you loose stools. If you have a patient who has a seizure disorder, you may not want to give them naltrexone bupropion because bupropion will lower seizure threshold. And if you have a patient who is very affected by nausea and can't tolerate it, you may not want to give them liraglutide or semaglutide because that's the side effect. All right. You're going to hear about how some patients are not going to lose weight on these drugs. So if you don't get a 5% weight loss at 3 months, you got to stop the drug and give them something else. It's not going to work no matter what you do. Okay. And you want to match the medications to your patient profile. So again, phentermine is not recommended for patients with uncontrolled hypertension, a history of heart disease or arrhythmias, or a history of seizures, also with naltrexone bupropion. And if you have a patient who is depressed with obesity, who's on an SSRI, you should think about phentermine topiramate because it's not going to interact with the SSRI. If you have a patient who's also smoking, consider naltrexone bupropion because it may also help them quit smoking because of the naltrexone. Patient with diabetes and obesity, this is what this conference is about, definitely consider liraglutide because it can also help them lower their hemoglobin A1C. A patient with obesity who also has migraines, topiramate can treat migraines, so consider Fentope. So you see that not one suit fits all. There are patient preferences. Also, injectables versus pills. You may have a patient who really, really, really doesn't want an injection, even though it's a tiny little needle. So educating the patient is very important. So let's review. Patient with diabetes and obesity, obviously metformin, first line, it can also help the patient lose weight. Consider exenatide, semaglutide, SGLT2 inhibitors, which can also help the patient lose weight. Pramlintide, amylin can also help the patient lose weight. Depression, obesity, bupropion, first line, it's already an antidepressant, bupropion, naltrexone. Don't use paroxetine because it can help patients gain weight. Choose another SSRI like Lexapro. Consider naltrexone, bupropion because of the depression. Hypertensives and obesity, don't use beta blockers. They cause weight gain. Insomnia and obesity, do not allow the patient to take antihistamines at night. They cause weight gain. How about obesity and diabetes requiring insulin? You want to get the patient off some of that insulin, because if you put them on a diet without reducing the insulin dose, they're going to get hypoglycemia and they're going to overeat because the hypoglycemia trumps the appetite suppression, obviously. So combine metformin, pramlintide, GLP-1s, SGLT2s, and get them off some of that insulin. Patients with obesity and hypertension, consider ACE, ARBs, calcium channel blockers. Never give them a beta blocker. Let's talk about surgery a little bit. Best long-term option for weight loss. Definitely. This is, again, average weight loss. 33% with the Roux-en-Y gastric bypass in 1 to 2 years. And then, yes, patients, all of them, will regain some weight. But by 20 years, you're still getting an 18% weight loss. Even though there's been weight gain, you still, over the long term, get a weight loss. There is weight regain. About 20 to 25% of patients struggle with considerable weight regain. What does that mean? Over 15% of the weight loss is regained. What do? Many of us have given pharmacotherapy after bariatric surgery. And here's the results of analysis of our database when I was at Boston Medical Center. And here we have patients in the blue line who've lost weight, lost a good amount of weight loss, and roughly has kept it off over 6 years and not required medications. Here is patients who've had inadequate weight loss or weight regain and have gotten medication. And as you can see, they've been able to, parallel, even though they haven't lost as much weight as the other group, they've been able to lose some of that and keep it off. So it does work. And here's another study that looked at their retrospective databases and found that indeed, with patients who have lost inadequate weight or regained weight after surgery, giving them medications, and the most used medication in this particular study was topiramate. It helps get patients back down in their weight. So this is a graph of a patient who's done that. So patients started off at 371 pounds with a high BMI in the 50s, and then lost weight with diet and exercise, regained, and then at a certain point, so diet, exercise, and medications. What medications? Metformin, phentermine, and topiramate. And then regained despite those meds, got a lap band way back when we were doing them, lost weight again, went down from 371 to 330, and then started to regain here because with the lap band, we got a lot of weight regain, and medication restarted here, then lost again very well to the point where they were down 100 pounds because of the lap band and 3 medications, but then regained again, and then again down here. So it's a journey. This is a journey over several years. We are looking at appetite suppressants. Are there other drugs on the horizon that may target other mechanisms? For example, metabolism. Yes, there are. They're far down the line because when we study these drugs that alter metabolism, we get bad side effects such as clotting disorders. So, and that's the methionine aminopeptidase 2 inhibitor that was studied, great weight loss, but then there were some deaths from pulmonary emboli. So they're back on the bench to try to figure out if they can get the same weight loss without that terrible side effect. And there are other medications that are novel mechanisms here that are being looked at, but certainly the ones that are coming down very soon are still appetite suppressants. We can't really break through the increasing metabolism of nutrients without getting terrible side effects. What about surgery? Can we figure out a way to send patients to surgery who are really going to get benefit, the best benefit? Right now, we look at the BMI and we decide based on the BMI. Is there a better way? Is there a way of identifying patients with high BMI, but also a lot of disease, inflammation? There is. So if you look at, the type of fat, and the more inflamed fat leads to more diabetes, leads to more hypertension and heart disease. And so we have to look beyond the BMI. And how do we do that? Well, there are these new classification criteria that you can find on the web that can help. However, when you try to change practice and utilize these, sometimes you, if they're brought into guidelines too early, you can really damage the acceptance rate of patients to bariatric surgery, because suddenly if governments adopt this new guideline, we suddenly get a situation where you have a BMI of 60 without inflammation, and they're not deemed candidates. And again, this doesn't address individuality. So we have to be very careful of these. There are also limits in accuracy in body composition measures to get a better idea than the BMI of what's fat and what's muscle. So you know that there are athletes out there with high BMIs, but they're all muscle. So how do we address? They're candidates for surgery, believe it or not. So what do? Well, we can do these great MRIs and CTs and X-ray, absorptiometry, IDEXs, but they're costly. You and I can look at a patient who's an athlete and say they're not a candidate for surgery. We don't need a $300, IDEXA. That's the issue. It costs a lot of money to do that. One size does not fit all, and that's the bottom line here, is that we have a diversity of obesity. And so if you put everybody in one group, the child who has obesity from age 5 is very different from someone who gradually gains weight over time and at age 65 has obesity. And we need to recognize this diversity because a different method is going to work for that 5-year-old who becomes an adult than the one who has obesity at 65. Okay. And so people have studied and tried to develop treatment paradigms for databases. So this is a bariatric surgery database that was studied and published, and they found that they were able to identify 4 different types of obesity. All right, there was and they did this, they just looked at the data, so it's not perfect. So there was one class that had diabetes with a low HDL, went to surgery. Another class that had disordered eating went to surgery. Another had mixed of both. And the 4th class was extreme obesity, early onset. All right. And they then studied these retrospectively and found that those in classes 2 and 3, i.e. disordered eating and mixed, had larger 3-year weight losses than their peers in the early onset extreme obesity, suggesting that that early onset extreme obesity had a more a more extreme type of obesity that wasn't treated as well by bariatric surgery, illuminating that these patients who start having obesity early have a very, very, very genetically programmed elevation in their body weight set point because of the environment. So the environment's the same for all of us, but some people have a very robust ability to store fat from this environment of easily available food. Guess what? It's not their fault. It's their genes. And even surgery doesn't hit it. That's what we learned from that study. All right. What else? Other research, we have this theory that hasn't been proven in humans, but has been proven in rodents, that there's hypothalamic injury caused by overfeeding all this food, which then causes this feedback loop where the high fat, high sugar food causes inflammation, and the signals, and the inflammation is in the hypothalamus, the signals coming from the gut that you're full doesn't get through. Calorie is a calorie, but the signaling is dysfunctional, and those people defend a higher body weight set point. Very compelling, but we haven't proven it. Another theory that some people produce more insulin than others based on eating, all this processed food, which drives fatty acid storage and away from oxidation. And the hyperinsulinemia is first, and then you get the obesity. A calorie is not a calorie if insulin levels are high. And then there's a third theory, which involves the genes, and whatever genetic profile you have governs what you store and what you burn. And a calorie is not a calorie, genetics play a role. All right. And it has to do with mitochondria. And we think that it may be that all 3 theories have relevance. Okay. For example, hyperinsulinemia caused by genetics, exacerbated by high sugar processed food, leading to hypothalamic inflammation and defense of a higher body weight set point. We got to prove all this. What about diet in the last few minutes? Well, many studies have shown, now this is the Pounds Lost study, showing that, giving patients different combinations of a low calorie diet, more protein, more fat, more carb, doesn't matter in the long run. These 800 participants got a low calorie diet with different macronutrient contents, and it didn't matter what of these three diets were assigned, patients lost the same amount of weight at 2 years. However, in re-looking at this study, patients had blood stored, and they looked at different FGF21 variants. FGF21 is a gene that, you know, promotes better metabolism of carbohydrate versus fat. And the conclusions after looking at this suggested that certain genotypes may interact with carb fat intake, and that the low calorie, high carb diet was beneficial for those patients carrying the carb intake decreasing allele of FGF21. Okay, so they saw that there were differences in body comp and improving body composition for those patients who had that allele. We need to do more work on this. That was just one gene. Another study looked at this and looked at low fat versus low carb diets, as long as they were healthy, not processed. After 12 months, again, found no differences, 5.5 kilograms versus 6 with the two different diets. And also looked at certain genotypes and found no difference, but they only looked at a few genes. So again, not great. So, but this conclusion was, doesn't matter what type of diet you're on, just cut added sugar, refined grains, and highly processed foods, and you'll have a better time losing weight. All right. And if you don't want to count calories, just eat plenty of vegetables and whole foods, and you'll lose weight. Okay. So then another reanalysis of pounds lost showed waterfall plots, which is every single patient who lost weight here on the 4 different diets. And so on the left, you see patients who lost a lot of weight on the diet, okay? And then on the right, patients who gained weight on the diet. Believe it or not, this is, you know, the heterogeneity here. See, this shows heterogeneity. And you know, yes, you can say, well, we don't know if they were on the diet. Fine, but you still have this heterogeneity, okay? And then if you look at the different genes, this is what you get. How are you going to get any guideline from this stuff? We need to do more work. We don't have it yet. So take home points. We can't really say too much about precision medicine from the pounds lost study, except that if you eat more protein and more fiber, they're associated with weight change. Consumption of more dietary protein is successful, okay? And also if you increase fiber intake, you have more success. So more protein, more fiber, that's the bottom line. Adherence, not the diet, predicts success. We knew this before pounds lost. And then a little bit about physical activity. We need to do the same work that we're doing with diet, looking at exercise. Right now, we know that the more exercise you do, the more you can lose weight, and maintain that, okay? Rather than doing less exercise. That's all we know. We don't know anything about who should do more aerobic, who should do more resistance. And the calories expended, you know, that's going to be different. Some people, especially when they lose weight, they have more muscle efficiency, meaning that if you eat 200 calories, you do better. The muscle burns less of that. You don't want that. You want the muscle to burn more, but so there's a lot more work we need to do about that. What we do know is patients get a better weight maintenance if you see them regularly, at least every 3 months. All right. Studies all show that. And so weight must be managed. Obesity is a disease. You don't give patient diet, exercise, and a drug and say, you're done. You see them. So in summary, there's no one path to weight loss due to the obesity heterogeneity. Medications are safe and effective, but you have to try them in individuals. You get the new drug that you're going to hear about, giving you great weight loss, but it's an average. There are more medications coming down the pike. We hope to hit different mechanisms. You got to look at fat content. Look at the BMI, but also look at the comorbidities, especially diabetes for bariatric surgery. And then high quality diets, high protein diets and exercise are the best strategies to lose weight, no matter what type of obesity you have, but not one suit fits all. Thank you so much for listening.
Thank you so much, Dr. Caroline. And we invite you to participate in the panel discussion, which would start approximately an hour and a half later, and also to take questions at that time.
Happy to.